This is R1 and 3 Autoethnography with your host, Stephen. On today's episode, we have Dr. Matic. We're going to be speaking about getting help, where to get started, and developing a secure patient-physician relationship. So before we get started, you got to know that I'm not a medical professional, and you should see your doctor if you're concerned about your mental well-being.
I'm Dr. John Matic. I'm a family physician. I've been lucky enough to been working with the Student Wellness Center for just over 10 years now, since 2009.
Today, we kind of want to look at some of the challenges and some of these questions I have about, getting help with a mental illness. But before we do that, you have something that you want to present, right?
Yeah, there's we know there's a lot of interest in ADHD and how it relates to mental health concerns, mental illness, challenges that university students often recognize. And so actually we have a series of ADHD Education series, usually 5 parts. Each part is presented by someone else just to show kind of the challenge with ADHD and showing how it can affect different aspects of your life. So it's myself, family doctor, who presents, community mental health nurse, a dietitian. Counselors are also involved with the presentation, and then someone from the Access and Equity Services advisor for academic accommodations. It's actually a really fun talk. We've been doing it for about 4 years now, normally first semester and second semester, and just kind of going over a couple things. So the one that I go over is actually kind of the introduction to ADHD. And it's really cool. One of the main resources is a guy named Dr. Russell Barkley, who has a great philosophy and a great approach to ADHD. And he kind of calls it the diabetes of psychiatry, where it's really common. We know that with diabetes, medication is a big part of it, but not just medication, that you need to make all these adjustments to your life so you can really take control of the situation and you're in charge rather than having the diabetes take over. And so he uses the same analogy that medication has a role with ADHD, but it's also the life skills that you learn and develop that really help you manage it. It's an old disorder. ADHD, a lot of people think it just came with the internet. It's actually was first described 1775, same year that Paul Revere ran through the town yelling about the British coming in. Normally affects about 5 to 10% of children. Some people talk about, do you grow out of it? They do describe that it's about 3 to 5% of adults who are still diagnosed with it. So there's definitely a decrease that somehow, whether the disorder becomes under control or whatnot, that there's more children than adults affected. And 3 main features. You've got impulsivity, hyperactivity, and inattention. And there's a couple different examples. Again, I apologize if the audience already knows this, but in case there's someone who's new to the topic, I still like to go over it. So impulsivity is, someone who blurts out, interrupts other people, makes important decisions without really thinking about what could happen behind it, reckless behavior, accident prone. These are the people who look and act like Mr. Bean. Hyperactivity, this is kind of that classic Johnny in the corner in grade 3 jumping around just because he can't help but climb the walls. So, a lot of running, a lot of just more activity than needed, always on the go, has problems playing or engaging in kind of boring activities. So people who can't finish watching a movie at home, really good example. Talking way too much, leaves a situation where it's kind of expected for you to keep sitting, just finding it hard to sit. And then the symptoms of inattention, and this is more classic for female individuals with ADHD. So as children, everyone notices Johnny climbing the walls in the corner, but everyone misses Susie when she's daydreaming and looking out the window. So it's more common for women to be diagnosed at an older age. So those are the ones who make mistakes, miss details, have a hard time following instructions, often doesn't appear to be listening or has difficulty organizing, a lot of those kind of features. So those are the three pillars, but really what it translates to is this concept of executive functioning, or self-regulation, where it actually affects a lot of different aspects. So like actually starting something, a lot of people with ADHD will describe, I just have no motivation. Like I'll sit down and then I'll end up doing something for 2 hours. I've lost all that time. Just problems with focus, problems with effort, emotional regulation. They're the ones who seem to fly off the handle really quick and then settle really quick, but they're the ones who get super frustrated, whereas other people kind of go, I don't know what's going on with you. I don't know why you're doing this. They're the individuals who seem to be liars, because they'll say, yep, no, I'll do it. And then when someone reminds them an hour later, did you do it? They'll go, sorry, what? Oh, crap, I forgot, right? So issues with memory and just issues with time, right? They're the ones who they either need to constantly look at a watch, or they're the ones who go in the basement and then turns out 6 hours later they come back up going, I don't know why I was down there so long. And then just this idea of like kind of self-monitoring. So again, that ties into a lot of activities in the future, because if you're kind of have a hard time going, oh, this may not be a good idea, you can definitely get into a lot of trouble that way. So talking about these different subtypes and how it affects kind of your executive functioning, you've got basically different types. You have ADHD, primarily inattentive. You have ADHD impulsive, hyperactive impulsive, and then you can have a combination where you're actually both inattentive and hyperactive. You can be diagnosed with all three. The challenge is, and what can actually happen is that it almost doesn't matter which one you're diagnosed with, because depending on the situation you're in, you're going to switch. You're going to switch from inattentive to hyperactive, or both at the same time. So classically, ADHD is a disorder that shows up in childhood, usually between the age of 3 and 6. Most present before the age of 13. If you happen to be in a household with really strict parents, really rigid schedule, you may not even be aware, because you're just so used to following the schedule that it's not until you get out of that environment that people will actually start struggling and go, hang on, why is this happening to me? They think it's a neurodevelopmental disorder. It's likely genetic. So if your mom or dad has it, 80% chance you're going to get those genes. If you have it, there's more than a 50% chance that one of your parents have it. There's some other factors they think involve too: tobacco and alcohol during pregnancy, or low birth weight, or low socioeconomic status. But genetics is the big one. They've done lots of studies on this, looking at MRIs, looking at different parts of the brain, and they've definitely found that there is dysfunction in the prefrontal cortex. There's lots of beautiful pictures showing how this lights up and whatnot. What it comes down to is, at a neurotransmitter level, the brain in a neurodiverse individual, so that would be someone with ADHD, actually has deficiencies in dopamine and norepinephrine. And so in someone who's neurotypical without ADHD, their levels are unaffected. They are where they are normally expected. One of the challenges is to get diagnosed. I think we'll talk about that later, but the short version is either you need to see a doctor, so either a family doctor or a psychiatrist, or you could go for a psychoeducational assessment, and all those are available at the U of S campus. Again, it can be challenging to navigate that. So yeah, we talked earlier about how more kids than adults have it. So about a third of kids diagnosed actually seem to not have it as an adult. I don't have an easy explanation why that is. The other challenge with ADHD is that it can overlap with a lot of other things. So that's your anxiety, depression. 10% of people with ADHD can actually have tics. Conduct disorder, oppositional defiance disorder, mood disorder like bipolar. So that's one of the challenges in diagnosing it. It's not kind of a quick, we just take an x-ray of your head and we know exactly you have ADHD. It can actually take time to sort out, is this ADHD? Is this anxiety? Is this both? So sometimes I run into individuals who kind of go, okay, so I have ADHD. What does that mean? The reason why it's important to know is it's not just an academic disorder. A lot of people just think, yep, I have ADHD. It just means I can't study well. The concern is that it actually affects all aspects of life. And so individuals with ADHD will have higher risk of injuries, higher risk of problems with academia. We talked about it, higher risk of relationships, more problems with low self-esteem. Because they make decisions they end up regretting. A lot of substance use is involved. Motor vehicle collisions, legal problems. These are individuals who go into things that seem to be high adrenaline. So we're talking about the people like jumping out of planes, working emergency, being paramedics. Interestingly enough, even the entertainment industry probably has a higher than normal percentage of ADHD for people who just like to be on display. So it really does affect all aspects of life. And so if you don't recognize it, you don't manage it, you can run into a lot of problems. So once a diagnosis is made from a physician's point of view, then the question is management. And as kind of this education theory shows, it's not just having one aspect. There's a lot of different aspects to consider. So one of them is even family education, whether you're a kid or an adult. If your family isn't on board, it can make it a lot harder. And then obviously medication. One of the reasons why medication is important is that this is a medication that works really well for a lot of people. The stats show that probably of all the psychiatric medications, this is the most effective. It works up to 88-90% of the time. In comparison, most antidepressants can work up to maybe 60% of the time. So they help, but man, the ADHD meds really make a difference. Again, it's not just the meds that will be optimal management. It's a little bit of everything. With the ADHD meds, of course, any pill you get from a doctor, there's going to be risks. So can't use it in people who are pregnant. If they have bipolar disorder, they're going to make that worse. If they have cardiac disease, that could make it worse. If they already have psychosis where they're out of touch with reality, that's going to make it worse. Like I said, the side effects, it can make you lose an appetite, get you nauseous. If you take it too late, have a hard time falling asleep, nausea, vomiting, the whole bit. There are a couple other options as well, non-stimulant medications, but certainly that's something for you to discuss with whoever's prescribing your meds. So that's kind of a brief overview of diagnosis, a little bit of history, and a little bit of management. That is just one part of the talk that we present, and then the part I love actually is after the talk when people come up with questions, and there's kind of a certain couple topics that always come up. And it's just great seeing kind of how people engage and actually see how people support each other too through, kind of a challenging time being in university.
You mentioned a lot about kind of symptoms and traits of ADHD there. I know that, especially with the internet, there's a lot of access to information now. And, if someone was to think that they had a mental illness, albeit ADHD, anxiety, depression, how do you draw the line kind of between mental health issues or a mental illness?
That's a great question. That can sometimes be a tough one. The short version, I remember one person putting it best: if you think you need help, you should go for help. I wish I could say there's a clear, this is exactly the moment that you need to go, but it can be pretty variable for people. So basically, if you feel like you're suffering, if you feel like you're in a bad place, you're not doing well, it's affecting you, not just yourself, but it might be affecting relationships, your schoolwork, your family life, your work environment. If that seems to be a problem and you're thinking, I wonder if I should go check it out, then check it out. Let's listen to that voice in your stomach or gut or wherever it's coming from. You're asking about, could it be an actual mental illness versus just, is it a coping issue? That sometimes, if you're not comfortable figuring that out on your own, that's why you reach out for help, right? And whether that's, a family doctor, whether that's a counselor, on campus, we've got a lot of different resources, just asking for assistance. Even, there's situations where people reach out to professors and the professors will find out, okay, what resources are there? Mental illness is definitely on the rise. We know that the rates of depression, anxiety are increasing. The pandemic has not been kind for that kind of issue. And so if you already had mental illness concerns like depression, anxiety, suicidal thoughts, it hasn't been easy for the individuals with that. And so that's kind of the time that you want to ask for help. You're asking about when is it a mental illness just versus mental wellness? And there is a bit of a difference between that. Mental illness is a pathology. That's an actual disease that someone has to diagnose. And that's typically by some kind of healthcare provider, typically a family physician. Certainly nurses and counselors can give impressions and advice as well for what they'd be worried about. Mental wellness is how are you doing in general? And that's kind of your like, are you eating? Are you sleeping? Are you relaxed? Are you enjoying life? Are you doing the things you need to do to take care of yourself? So someone can have a mental illness. A good example is like bipolar disorder that can be quite significant. But if they've been diagnosed and they're medicated and they're doing everything they need to take care of themselves, they may have a mental illness, but it's under control. And so their mental wellness is actually pretty good. You can have bad mental wellness without mental illness, which basically means you don't have a formal diagnosis of anything. You're not suicidal. You're not wanting to harm yourself. You're not riddled by anxiety, but you're not eating, you're not sleeping, you're not doing well. And that's another reason to reach out. So it may be that, whatever worked for you in the past to cope and manage isn't working anymore. And checking in with someone who has skills to kind of assess you, to give you advice, can check things out.
Yeah, that's a really good answer. I remember when I was first exploring a lot of this, getting help, I kind of had like a lot of self-doubt and whatnot. So how would you kind of approach that? You said that if you're questioning, should I get help, then that's probably when you should get help. Like, how would you kind of, what would you say to an individual that's kind of on the line between this is kind of not real, between like, I can deal with it myself, sort of?
Yeah. So, can I do it by myself, or do I need help? At the end of the day, I'd always suggest to people it's probably better to explore the options of help, because I'd rather see someone asking for help that actually isn't too bad, rather than someone struggling to a point where they've gone too far. So that sometimes the analogy I make is it's kind of like you're on a boat. The boat's in trouble. It's taken on water. You're worried that it's going to sink. And for different reasons, people say, you know what, I'll just take care of the boat on my own. Whether that's shame that they haven't been able to manage the boat, whether that's embarrassment, they don't want to see anyone to see the shape of the boat. I go really far with this metaphor. The more water that takes on the boat means the more work it takes to save the boat. And so for people who say, I'm always getting checked out because I'm always freaking out, in some ways that's not a bad thing, because then the boat never gets that damaged, right? Because they're checking in earlier. And so earlier is always better than later, because the concern is if it's later, that boat might be too far gone, right? And if you can't, then you've got a Titanic situation. And obviously that's a horrific example. I'm going to stop that one right now. So I feel like Doctor Who when he goes with his timey-wimey example, and he's kind of like, okay, I've gone too far with that one. I'm going to stop that one. So yeah, so basically reaching out for help is not a sign of weakness. It's actually a sign of strength, right? Knowing that you need to know what your limits are. They've actually done studies about failure. We've got in our pop culture mentality that you should never fail, you should always exceed and be perfect and 100%. And the reality is that's great in movies and comic books. That's not real life. That's not realistic. They've done studies and they actually suggest you should fail about 15% of the time, because then you actually know your boundaries. And so it sucks and it hurts when you feel like you've failed at something. I haven't been able to manage this on my own. I haven't been able to succeed. And we're forgetting that there's value in failure, that there's value in learning what are my limits, what am I capable of, and there's value in learning how to ask for help and how to do that. Because when you go through it, and later on, if you're able to give back to the friend, the community, the family, whatever it is, with your own experiences, that's going to help someone else when they're going through it. So the original question was, how would you help someone who's waffling on the line? It pays off dividends. At the moment you're in pain, you're struggling, you don't know what to do, the people around you, whoever that network is there to help you out. And it just takes the strength of saying, you know what, I think I need some help. People who truly care about you are not going to judge you. People who judge you are not the people you want to reach to. You want to go somewhere where you feel safe, you know that they're going to support you, give you time for whatever you need, whether that's grieving, whether that's a moment of rest, and then help you develop those skills. They can't do everything for you, but it's giving you the time and the space and the ability to figure out, okay, what do I actually need? And then how do I proceed from there?
Mm-hmm. So, I guess I'm just going to keep going along with that analogy of someone who's on the cusp. Say that they do decide that they want to get help, and the way that they're going to do that, because there's so many options, is they want to speak with their general practitioner.
Yeah.
So how would you, I don't know, recommend that individual prepare for that conversation with the general practitioner?
That's a great question. It does depend on your family physician, I won't lie. Each family physician is kind of like a cook, where they all have their specialties and areas of interest. I've been fortunate enough to work at Student Wellness, where we've put a lot of effort into mental illness. We recognize that we've been lucky enough to bring adaptations into the clinic. And so certainly from the point of view of student wellness, mental illness is something we're really comfortable with. We recognize the challenges, and we're used to the university student population. If you're an individual who actually has a family doctor in the community, that is a different situation. You're talking to a family doctor who, seeing everyone from, 4-day-old babies to 90-year-old individuals. So they may not have as much expertise. So preparing yourself, you may want to do kind of okay, so what are my problems? You kind of need to do the grocery list, where you go over, these are my concerns, right? I'm noticing that I'm not sleeping at night. I'm noticing that I can't eat. I'm noticing that I've started skipping school. A lot of things that some people can feel ashamed about. These are family doctors who you may have known since you were a kid. Your parents respect them, your siblings respect them, and so you might feel a little embarrassed talking to them, and just want to let you know, literally these doctors have seen everything, and they're there as your resource. It's easy for me to say you shouldn't feel judged, but some people might. And just remember that they're there as a resource for you. They're there to provide help and support for you. Because they don't see university students as much, I have talked to some individuals who feel like they've been put off or ignored or not listened to. There are resources both between the family physician and in the community to help out your situation. We're creating inroads as well, where family physicians are aware of resources on campus, and we'll say, you know what, this is something, I can't manage everything. In some way, the family doctor is like an air traffic controller. They're not a specialist in everything, but a really good family doctor is going to have a really caring ear for the concerns you're going through and figure out, okay, where do I need to send you to help you? Not every family doctor is an expert in ADHD. It's actually in the community a lot less common compared to like the heart disease and lung disease. But every family doctor is going to have a lot of experience with anxiety and depression and a lot of those issues that can overlap with ADHD, as well as just generally affect anyone. And so they should be able to help with at least a baseline, getting you set up for kind of the next couple steps.
Yeah. So, say this individual who's on that line goes, prepares, and speaks to their physician. Yeah. Now, this is kind of challenging because I could see it from both sides. If that individual were to feel invalidated because the doctor kind of doesn't acknowledge some of their experiences, how would you approach that? Because I know that your opinion as a medical professional is important, but a lot of people that I've interviewed have spoken about, misdiagnoses or things along the line of that. Yeah. So how do you approach that?
So first, although it's not my responsibility, I'm still going to apologize for people's experiences. Not like I'm personally responsible, but the reality is the system is run by humans. So as much, I'm so sorry, I'm going to make another Doctor Who reference. There's one line the 8th Doctor says where he goes, being a doctor is a bit of wish fulfillment, right? Because you want to save everyone and you can't. The ultimate goal is to help everyone. The reality is that we're human beings, and so there's going to be problems brought in because we're human beings. The concern of individuals being invalidated, not being listened to, I've run into those situations. And certainly It's an issue of communication. And actually, when it comes to physician complaints, usually the complaint isn't knowledge level or they screwed up the procedure. It's more about communication and bedside manner. And so if you can't get along with the physician, it doesn't necessarily mean either party is in the wrong. It just means it's not a good fit. And so I would encourage a person who says, yeah, you know what, he didn't listen to me. I'd encourage you to persist, not necessarily with that individual, but accessing some kind of care somehow, because there is resources in the community. There's mental health intake, there's crisis line, there's emergency, there's walk-in clinics. There's a lot of different options. There are some people who their personality is, I'm just going to try once, and if I get shut down, that's it. I'm going to just stew in what I'm in. And in some ways that's comforting, but the problem is that's a comfort in the brain that actually doesn't help you. If you're not happy with your current situation, then you need to keep trying. We talked about this, right? Failure is okay, and it's okay to lie down and bleed for a while. That's another terrible quote, but I like that one. But after a while, you have to get up and decide, okay, what am I going to do next? So if it was a bad relationship with one physician, that doesn't mean the next one is going to be bad.
You know, you kind of spoke about that individual who may fail once and not try again. So I guess how would you want to speak to an individual who feels invalidated in their experiences, because there is that line between your patient, self-diagnosing and you as a professional diagnosing. So how do you kind of approach that, without kind of stepping on people's toes?
Yeah. So I think the one point that you've mentioned a couple of times I didn't directly address is that invalidation. I think first you have to validate the individual's concerns that, yep, the last experience you had was horrific. Because you're not going to get anywhere if that individual doesn't feel like they've been listened to. Because that's one of the things I've learned the hard way with mental health is that if the person doesn't buy into it, if they don't feel that they're heard and they want to take part of this, it doesn't matter how many times I say you should go see a counselor. It doesn't matter how many times you should take a medication. If that person doesn't feel like they're part of the process, that they're being told what to do, there's no reason for that person to follow the advice because they don't feel like they're part of the process or they feel like they've lost their control. A key for a good patient-physician relationship is that kind of mutual respect, the understanding that at the end of the day, the patient's in charge of the care and that anyone involved in the care team is really like under the control of the patient, to be honest, right? Like again, pop culture references. In the 50s and 60s, you had like old shows like Dr. Kildare and what was the other one? Can't think of it. Where kind of the doctor was basically akin to God, right? Never made a mistake, always knew what they were doing, very paternalistic, this is what you need to do, nurse. That kind of aspect, right? And clearly wrong, right? Like the idea that the doctor's in charge is a real fallacy, right? This is a team effort with the focus being on the patient. And if the patient doesn't feel like their concerns are validated, doesn't matter what you do. No one's going to feel. No one's going to follow that advice. So if someone's invalidated, that's already the start of a challenging relationship. And I know I've met a couple patients who have said, I talk to all these doctors, they just don't listen. And so really it comes down to listening and that key of developing a relationship. And that might take time, building that trust and building that trust and relationship. That literally might take time. And I've seen that people are kind of skittish and they're almost scared to open up and be vulnerable. We're people in healthcare are really privileged to have the ability to help. And we're all, I think really we are going kind of with this higher moral understanding of we want to help people to the best of our abilities. And so just trying to find that common ground with an individual. It's when it happens, it's actually a really sweet moment. And then working on that relationship and finding the key factors that work for that person. I always talk about how each person, when it comes to mental health, trying to figure out that cocktail, because what's going to work for one person isn't going to work for another. And the only way I'm going to understand what that person requires is if I listen to what they're saying. I have to ask a couple of questions to kind of figure it out. But if I'm not listening to what they're saying, I can't figure out where to go next.
Yeah, for sure. And you spoke about developing that patient-physician relationship. So, as an individual who would come in with kind of these concerns, who may have been invalidated before, how would you kind of recommend a patient try and develop that relationship? Like, is there certain questions or is there certain things that you can say to kind of be more comfortable, feel more safe,
So you're asking what questions or how should the patient present themselves to figure out how to work with the doctor?
Yeah, sort of. In kind of a safe manner, because I
Yeah.
know that it's like terrifying to go to your physician and speak about, mental health challenges because, obviously there's that stigma, but also it's scary to be vulnerable. So
it's a challenge you're right. That's absolutely a challenge to be vulnerable, right? Like for some people, they overshare. They love being vulnerable. There's other people who they're a stone wall, and to get a crack in them, it takes a lot of work. From the patient's point of view, again, it's that it actually almost doesn't matter whether you're the doctor or the patient. It really comes down to openness and transparency, right? That the patient has to be honest with their concerns. And certainly if they've been burned before, I think it does them a good service just saying, you know what, I'm sure you're a lovely human being. I'm sure you're a very good doctor. I just want you to know that I've had a lot of bad experiences. And as such, I find it hard to talk to doctors. And I think some physicians will find that really refreshing, right? Just admitting this is the problem I have right at the front, right? It definitely does you service just to be clear with what your expectations are. From the medical point of view, for family doctors are actually trained in something called fifing, which is like trying to understand what the patient is really wanting out of it. And if you talk a little too much in circles, if you're not being open and honest, then it makes the doctor try to guess your motivation, and that just leads to kind of double talk and not clear expectations. But if you actually just say, you know what, I'm worried that something's going on bad in my life, but every time I've talked to a doctor or a counselor, I've had a horrible time. I think that'll prime the doctor going, okay, I have to be a little more sensitive here. I have to be a little more careful here. And like I said, like the problem with the medical system is run by humans. So there's going to be mistakes, there's going to be errors, and just realizing like, and especially in this time when everyone's a little more on edge, that we have to remember to be a little more compassionate, which is really hard when you're busy freaking out and you're mad and you're angry. Because when you're hurt, you're a bit like a wounded animal. You just want to hurt the people around you. So it's easy to say, oh, you should be more compassionate. But when you're too busy just trying to take care of yourself, it's pretty hard to think of others.
Mm-hmm. Yeah. I had something, but I lost it.
Sorry.
No worries. So, you earlier you spoke about kind of that care team. So how would an individual who kind of, starts their diagnosis, is going through kind of exploring it with their physician, what does that process kind of look like?
Again, it depends on where you are. So because I've been at student wellness for the last 10 years, I'm going to talk about that experience. So some clinics are fortunate enough to do what's called collaborative care. So that's where the different aspects of the healthcare team work a lot together. So in our example, we're very fortunate. Great example is the eating disorder team. So a patient may present with concerns of eating disorder, whether they are comfortable admitting it or not. The doctor may tease it out. Doctor has resources immediately within the clinic, including a dietitian, counselors, psychiatrists. They could all work together, coming up with a care plan, working with the patient, saying these are the areas of your strengths. These are areas we need to work on. These are some of the strategies that might work. These are the medications that might need to be involved. So sometimes the care team develops around a person without much effort just because the system is in place. For individuals who are in the community, those networks are available. And actually, the health region is always trying to improve connection among different services. So in the community, there's still access to dietitians. There's still access to psychiatrists and counselors because the system's a bit different out in the community. The counselors aren't necessarily connected to the family doctor. So there may be a little bit of disconnect that way. But the psychiatrists and family doctors will communicate. Those teams are in place, and a combination of both the patient reaching out. So often patients will, in the community, make their own arrangements for the counselor, and the physician will access, the psychiatrist and maybe the dietitian or something like that. As kind of things progress, that's kind of how you develop a team. So typically a team isn't built in a day. It's a bit like Rome. It might take a little bit of trial and error, a bit of, okay, what works for you, what doesn't work for you. Certainly, I've had my share of patients with depression who don't find counseling helpful, and other patients who find medication is a problem for them, but they love what they get out of counseling. So again, it kind of comes down to that, what cocktail people need to work for them.
Yeah, for sure. And, on campus here, where would you want to refer someone to, if they don't really know what's going on? Where would you say they should start the whole
process?
Yeah.
So certainly, and so this is true for anyone who doesn't have a family doctor. Or the other joke I make is, you're sick of seeing the doctor who's been seeing your parents your whole life. You kind of want that privacy. You want something that's yours. So it's literally as simple as emailing or phoning the Student Wellness Center. There you have access to family physicians, counselors. If it's a mental health concern you're presenting with, they have something called the intake team, where they bring you in, they ask you some questions, and they're going to help triage. They're going to understand how serious the issue is for you and help guide you on your path to who you need to engage with, whether it's a family doctor or counselor. So those are a couple of the resources available for people who are struggling, maybe not necessarily mental illness, but like financially they're having problems, or they're homeless, or they're having issues with immigration. There's a service called Student Affairs and Outreach, who are kind of like social workers for university students, and they kind of have access to lots of different services. They work together on campus, like Isaac, or campus security, or whatever kind of issues you need addressed, and help sort out, okay, how can we help with this issue? So that's just a couple of examples. International students, you've got Isaac. So there's actually a lot of access. At the end of the day, just reaching out for someone, because we're all on campus, we know that there's a lot of these resources. If whoever you reach, and I'd mentioned earlier, even professors, students will reach out to professors saying, I think I have a problem. A lot of people on campus know, I may not have the answer, but I might get a good idea where to send you. And so just asking for that help and then given the advice of where to go next is certainly one way to do it. Short version, contact Student Wellness Center. Somehow you will get access to the service that you need. It may take a little time. It sometimes can take a day or two to sort out exactly what service you need. And that's the key with any kind of health relationship. Unfortunately, if there's something urgent, you're having an asthma attack, you're worried you're having, you fainted and you're worried what the heck is going on, go to the clinic. We'll address that right away. Some other concerns can take time. And so developing that relationship and figuring out who you need on your team will take time, but it pays off in dividends in the long run.
Yeah. Now this is going to be a very general question. So I want to ask you, as a physician and as a person, do you have any recommendations in general to people who are struggling or trying to work through mental illness, like ADHD, anxiety, depression, or...
So don't beat yourself up. I think that's probably the first thing I would say, because there's a lot of people, especially with ADHD, but almost any mental illness, you feel like you're broken. You feel like, I'm not perfect. I failed. I have to give up because this is never going to work. And it's okay to sit for a few minutes and eat your bucket of ice cream and feel the grief. That's okay. It's okay to feel sad. But also recognizing that, remember, you have value, you're important, and you're important to other people, and you're important to yourself. And just remember that if you do need to have a little rest before the next fight, that's okay too. To keep going, right? It's a bit like that Dan Savage, It Gets Better program. where literally it does get better. There's going to be good days and bad days, and the reality is that's life. I wish I could sugarcoat and say everything's going to be perfect, but that's pretty naive of me. There's going to be good days and bad days. My memory is shot. There's a comedian who talks about sometimes happiness is just 10 seconds long, which sounds really depressing. But when the times are bad, sometimes just looking forward to those kind of few minutes of happiness might be just what you need to get through that rough time, because it can't be rough for the rest of your life, because life is pretty long. Knowing that there's people out there who, if you are hurting, whether it's your mom or your family or your buddy or someone online or a counselor, that there are people out there who do care about you, who do want to help you. And just, it sounds trite. It sounds trite to say keep fighting the good fight, but there is value, because when you get through it, you kind of go, frick, man, I did that. I got through it. That was tough. And now I can take pride in what I managed to accomplish. And it's probably never going to be, it's kind of like when you're painting that art that you've never painted before. You kind of look at it. Yeah, it's sloppy, it's crooked, but I did it. It's mine. I'm proud of it. And just knowing that with failure comes accomplishment when you try again. It's okay to fall off the bike, but if you never get back on it, you'll never learn how to ride it. So that kind of like expecting the bloodied knees, but also knowing you're going to be able to ride the bike. I think part of the challenge is this North American pop culture mentality of you must succeed at everything you do and it will be easy. And the reality is, like, certainly I tell the medical students when they're training, it takes 10,000 practices to get good at something. Like, it's great when you have a skill that comes to you easily and you don't have to work that hard. But the reality is that can't happen with everything. There are times that you're going to have to work hard, the blood and the sweat and the tears. Well, that's a Johnny Cash reference. There's going to be hard times, but knowing that with hard times comes the satisfaction of accomplishment. So it's a bit like farming, actually. You can't just get an apple. You kind of have to plant it, raise it, grow it, water it, nurture it. But at the end of the day, after all that hard work, you got a bunch of apples to eat, which is kind of sweet.
Yeah, I like that analogy.
That one was good.
Yeah. So, what was I going to say? I forget. I guess, how would you kind of recognize that an individual is starting to, I don't know how else to put it, but recover from their mental illness now that they've worked through it, recognized it, got that team, and they're starting to,
So from a medical point of view, we always talk about objective markers, right? Like things that you can actually measure, whether that's success in grades, whether that's there's scales that can actually measure amounts of depression and anxiety. Those are kind of boring scientific, what are the numbers? But that doesn't necessarily reflect reality. So we talked earlier about developing that relationship between the physician and the doctor. And I think the patient has to be honest, saying, I think I'm feeling good. And if they're comfortable enough to be open and vulnerable and saying, you know what, life was really crappy before and it's less crappy now. Or, you know what, it's working for me now. Like I'm finding the challenges I used to have are not there anymore. Or they just say, I'm genuinely happy. Or one of my favorites is being in a relationship doesn't mean that you're fixed, but it does mean that if you're happy with yourself and you're comfortable to be vulnerable with someone else, that's another sign of feeling good, right? I don't want to give the impression that being in a relationship means that's the only way to fix yourself. But if that's a choice that you want to go into, that's great. Basically, kind of having the power of saying, I'm making choices that are good for me and I'm liking where I am. That's really what you want to look for. And again, so the objective markers, it can be as simple as, yep, I can now take 5 classes instead of 4. Or I'm taking my 4 classes and I'm getting 80s. Or I'm working a couple classes and I'm working, doing a job and I'm loving everything. So it's really down to the patient how they're doing. Like I said, like there's a couple things you can measure, but at the end of the day, if the person is smiling at you, chances are they're in a good place.
Yeah. And, I'm only asking you about some of these objective measures and, some of these processes because I know that a lot of individuals, again, who I've interviewed have struggled with invalidation, especially self-invalidation. So just knowing that there is, objective measures, I think that's certainly comforting to know.
Yep. Yeah, and you're right, because some people, they're so hard on themselves, they don't recognize the accomplishments they make. They'll be like, well, I fell down, and you kind of have to remind them, well, you did walk 2 floors up. Again, another analogy, you had a broken foot last year, and now these couple months, you're able to walk the stairs you couldn't fall before. And so again, focusing on failure can drag you down. So it's again a matter of perspective, trying to recognize your accomplishments and recognize the areas of challenge and just trying to put them in perspective. They always talk about when you evaluate yourself, you're looking in a warped mirror, right? Because you can recognize other people's accomplishments a little more clear, but you might not give yourself that credit to yourself.
Mm-hmm. I just have a couple more questions here, and then I can send you on your way. So how would you recommend, I guess, a loved one, someone who lives with a person with a mental illness, I guess this is general because it would be more specific if it was a certain one, but how would you recommend that they kind of support that person?
That's a great question. You're right in that there's probably a couple general themes and then things that are specific for other people. So again, that kind of
sorry to cut you off.
No, sorry.
Let's just say like explore the general and then say something like ADHD.
Sure. So if someone's struggling with a mental health issue, I guess the first one is just remember to be compassionate and empathetic and think, this is a person who's going through a challenge. What can I do to support them? And that can look in a lot of different ways, but I guess it's kind of also some of this is really touchy-feely stuff. It also depends on kind of your language of love. If you're a person who thinks, if I set the table for them, they'll really appreciate that, that might be true. Again, it comes down to communication, just kind of asking, what do you need of me? Or what can I do to support you? So the family member, I would say, just ask what you can do, because some people do find it painful when you do stuff for them they don't actually want. And then some people want the attention. They want to be checked in all the time. And so I think literally you just need to check in with the person saying, well, what do you need right now? Do you need space or do you need support? And then just listening to what their needs are. So again, clear communication is a big part of it. Often when people are in the throes of a bad illness, they're going to be angry, they're going to be frustrated, they're going to be short, and just remember to give them a little bit of leeway. You don't want it to turn into like an abusive situation where the person's taking advantage of you or harming you, but just understanding that, if they are a little bit short with you, maybe give them a little space. If they're taking tens of thousands of dollars from you, there's no mental illness there. That's just robbery. But it's really challenging sometimes with mental illness, because some mental illness can cause people to act in ways that can be really harmful. And so it's this weird balance of taking care of yourself while you're taking care of the other person. So it brings to mind the analogy of when you're on the airplane and the oxygen mask drops, always make sure you take care of your own mask before you take care of someone else's mask. I remember an analogy where, I can't remember, it was one of those like celebrity addiction shows or something, where the family comes in and a counselor takes the person with the addiction issue and takes them off to the side and starts working with them. But then they have a counselor for the family who comes and talks to the rest of the family. They say, so this is a conversation. This is not an easy conversation. The person you're trying to help with the addiction issue may die, because that's one of the realities. And like, how are you guys going to do with that? So it's also coming to terms with the challenges of someone dealing with a loved one who has a challenging mental illness. And sometimes it can be really hard where, you have to take care of yourself in that kind of situation. You can't lose sight that you want to give everything up of yourself, because then you're not taking care of yourself. So it is this balance of, you want to offer to help that other person, but make sure you're aware of boundaries and taking care of yourself at the same time. So it sometimes could be really challenging.
Yeah. And that was a very touchy-feely answer, but it was good.
Yeah.
And, how would a partner support someone with something like ADHD?
So that's a really good one too. So with ADHD, so it does tie into addictions because we know some ADHD individuals have a higher risk of substance use. So that, again, that kind of example sticks. When we talked earlier about diagnosis and management, family needs to be aware of what ADHD is. So they need to have a good understanding of the disorder. It's someone who's it's not just the absent-minded professor. It's someone who actually has a disorder that they're never going to be quite as organized as someone else. They're going to need a little bit of extra support in terms of whether that's scheduling or allowances for this or that. So education. And then again, just communication. Okay, what do you need of me to help support you with this? And being clear and like, okay, I can only offer so many things. What are my limits? Like, I can't help you with this or that or the other thing. So again, clear communication and clear boundaries of what you can do to offer help the person. But then also saying like, I can't drive after 8 o'clock. It's too dark. So if you get stuck somewhere, I need you to understand that I can't leave the house. I've got the kids or whatever that is. So again, it's challenging because ADHD, people make decisions without thinking about the consequences. The other person sometimes feels the burden of, oh, now I have to deal with this. So trying to work together, ideally working on each other's strengths to figure, okay, this is how I can help you. We talked earlier again about how sometimes it's hard to diagnose people when they're young because the environment they're in is so structured, it helps support them. And so someone may need to help contribute to that, saying, I'm not going to remind you every day, but I'm going to put a bowl here, and then you always put your keys and wallet here. I'm not going to remind you that it's here. You have to remember that, but I've set this up. If you build that routine, that should help. And so sometimes little triggers like that can be helpful too.
Yeah, for sure. Now, do you have anything else that you would want to discuss before we end this, or?
I didn't prepare any jokes. I don't have any ADHD jokes now that I think about it. It's an old Norm Macdonald joke. I think that's the only one I can think of. See, he used to say, don't forget, laughter is the best medicine. Unless you're diabetic, then insulin's the best medicine. Yeah, I guess that kind of ties in with what Dr. Barkley was saying earlier, that ADHD is the diabetes of life. Some people claim you can fix it. You probably can't. It's like diabetes. It's going to be with you the rest of your life. But there's ways to manage it so that you're in charge. You're not at the mercy of your ADHD. You're in charge. It's going to be a lifelong issue. Is it going to be a lifelong struggle? That's up to you depending on what skills you develop. Like I said, it's no different than diabetes. There's a lot of people who stay on top of their diabetes. They do fine. And so there's no reason why, even with the diagnosis of ADHD, you can't do well. You're going to have your share of struggles. Everyone has their own cross to bear. But, showing up the best you and doing, what you can with the tools that you have, there's no reason why you can't succeed the way you want to.
Mm-hmm. And now, this is my last question here. What is your take-home message from this podcast interview? What is something that you would want to just, stick with everyone?
Wow. I always like final statements, and I never thought of one for this. I think the short version is just be kind to each other and take care of yourself. I think I'll just go with the touchy-feely one. This has been certainly a lot of people have struggled over the last couple of years with COVID, and I'll admit it's been a challenging time, not just as a healthcare provider, but as a person as well. And so I think at the end of the day, just be kind to each other and help each other out.
Yeah, that's a really good answer there. So if there's nothing else you want to talk about, I'm going to end the episode there. Alrighty, well, thank you for coming on, Dr. Matic. It was a pleasure.
Oh, yeah, this has been really awesome, actually. Thank you so much.
Yeah, I'm glad to have you on. I'm going to stop recording now.
Okay.
So hopefully you guys liked this episode. Make sure to check out our website in the description and subscribe on whatever platform you're on. You'll also find some resources and references we used for this episode in the description. We'll see you next time.